We are live, sir. I'll just check if audio is working or not, like on Facebook, and then I'll begin.
Okay.
Yeah, it's working.
Okay.
Good evening, everyone. Today we have a session on GI motility and IBS like symptoms in IBD patients. And today we have with us Dr. Zubin Sarma. And Dr. Zubin is an interventional gastroenterologist, and he is practicing at Medanta Medicity in Gurugram, Haryana. And he has actually been awarded with the National Gold Medal for Gastroenterology by the Vice President of India. And he's also trained in advanced endoscopy, including ERCP and EUS. And he has a special interest in neurogastroenterology and GI motility. In fact, he is one of the very few doctors I could find who have a special interest in these topics. So that's why we have him here to speak to us about these things. And first of all, Dr. Zubin, I would like to wish you a very happy Doctor's Day. And thanks a lot for speaking to us and agreeing to teach us about this topic.
Thank you very much, Nikhil. And I'm really happy that you chose to, at least we can talk about this particular topic, which we don't really do that often. Thank you so much.
Thank you, sir. So on that note, I think, sir, we can begin the presentation.
Okay, I'll just share my screen.
Yes, sir.
Okay, can you see the screen now?
Yes, sir. 1 second. I'll just fix it for the online viewers.
Okay.
Just 1 second. Yes, sir. Now it's visible. We can continue.
Okay, thank you so much, Nikhil. So right at the beginning, I like to say that motility and IBS or IBS like symptoms in IBD patients is not something we have studied a lot. It's not something we talk about a lot, and that is why there is a lacuna of enough literature or enough data available which tells us that what exactly goes wrong. But now in the last 10 years there has been a significant changes even in the mind of doctors and researchers, and we now start to believe that motility is at the forefront of even managing IBD patients. Because if you see classically, the main symptom somebody who has an ulcerative colitis or even for Crohn's is somebody who has a diarrhea or somebody who has bleeding with diarrhea. So along with many other symptoms, one of the predominant features. So motility remains at a main crux of why somebody presents to a doctor, and ultimately they are diagnosed to be IBD, in its various forms. So today, what I will try to do is I will just try to touch upon a few things: that what exactly is neurogastroenterology, what exactly is motility, and how does it relate to IBD, and where does it relate to it. And now actually we have started to believe that it is just a common spectrum, the central goal being that there is some amount of inflammation where the severity changes, but ultimately it's a spectrum where when you do find changes in the colon, you can diagnose somebody as IBD. Where you don't find changes, you just label them as IBS, but the core pathology remains the same. So what exactly is neurogastro? Neurogastro is a subspecialty of classical gastroenterology. So it deals with function and diseases of the enteric system. So when I say the enteric, I mean the GI tract. There are a lot of nerves in your intestines. All these nerves are something like they have their own small little brains. They are independent. They control a lot of functions. So a lot of things tend to go wrong with them, and neurogastro tries to identify them, tries to research them, and finally find a treatment for them. We also include a lot of psychological and psychiatric relation. I really I don't like the word psychiatric myself, but I believe that it is a disorder which actually controls your brain and your gut at the same time. But just for the common language that everybody speaks, psychological disorders are a part of neurogastroenterologies, which do affect your GI tract. And till now, we always thought, okay, colonoscopy is normal, he's not ulcerative, he's IBS, and we used to leave it at that. But now, testing is definitely available. It has to be evidence based. You can't just label somebody as IBS and forget about it. So we do have testing available to us. If you can see this particular diagram, your central nervous system tries to control your enteric nervous system. So try to think in such a way that your brain is your mainframe computer, right? And your enteric nervous system or the GI tract is like multiple mini computers, or lying in a parallel array. So your brain will try to control those mini computers by two primary mechanisms, something called as an autonomic nervous system, and which is a nerve, rightly, and one more is the hormonal system, which we call it an HPA axis, or hypothalamic pituitary adrenal axis. So these two, through hormones and through nerves, will try to control those mini computers. But the mini computers are smart enough to make some, their own decisions. They don't have to ask the daddy mainframe that, okay, can we do this? They can manage something on their own. And that is where it tends to get somewhere wrong. So it uses all this immune system signaling and the underlying environment that it creates all that dysmotility. This is a very basic model of how your neurogastroenterology works. So we deal with how your GI tract functions. When we do endoscopies and we diagnose somebody as ulcerative or colitis or Crohn's, we are only looking at the mucosa. We are telling you, okay, your mucosa is bad, you have ulcers, or you have some inflammation. We'll take biopsies, and biopsies, a pathologist sees and tells, okay, you have granulomas or you have inflammations. They don't check what functions. We are assuming that your functions are bad. That's why you came to us in the beginning. But we have to understand that neurogastro primarily looks at how your GI tract functions. On the right side, you can see control levels. Control level 1, 2, 3, and 4. So your higher brain centers are the control levels 4. That is the highest center. Then comes your, as I talked about, the autonomic nervous system. That is control level 3. Then your nerve, which is in your spine, that is control level 2. And then your nerves inside your GI tract. That is the first control level. And the affected means what organ is affected. That is your muscle, your mucosa of your intestines, and the blood vessels of your intestines. That is the vasculature. So these are multiple levels of controls. That is how we try to, and this is what, as neurogastro, we try to study. Okay, we have seen that mucosa is wrong, but how did that mucosa go wrong in the beginning? Why is this patient having diarrhea? All that is explained by neurogastroenterology. So this is a fact now. Your tummy or your intestines have equal neurons as your spinal cord, maybe even more than that. So your tummy is a brain in itself. So that is your second brain. In what I used to tell my patients, your second brain is not functioning well. And this is why this is important to know. It's a funny story, and we deal with every day. Every day I see patients, I'm not talking about only IBD, I'm talking about IBS also. And we usually give them, antidepressants, and they come back next day to us and tell us, sir, and in fact they're angry. Sir, ये आपने दवाई क्यों दी? ये तो नींद की दवाई है, ये तो डिप्रेशन की दवाई है, and why did you give us? I have to show them this particular diagram, and they tell me that you have a brain inside your tummy. So जो दवाई psychiatrist use करता है आपके first brain के लिए, we gastroenterologists have to use it in probably some lower doses, for your second brain. So all this complexity goes into why you are given all those drugs. So this is a diagram from basic physiology. It's a complex diagram. I'll try to slightly, modify it to make it simpler for everybody to understand. I already gave you an example of that mainframe computer and everything. So the classical model is on the left side. Okay, there's a mainframe, and directly it controls the organ. There is no in-between assembly. The current concept is that you have a mainframe, you have many chips around somewhere near your GI tract, and then you have the output. So mostly in motility or dysmotility, these mini computers or microprocessors that are in between your central control and the output, that's what actually goes wrong. That's what we try to identify. So when we talk about something going wrong in your GI tract, we usually divide them into three broad disorders. One is organic, and then there is motility, and there is a third group called as a functional GI disorders. Organic, you all know, you all have been through it. You know what is going wrong in your mucosa. The biopsies are wrong, and there are large also there's bleeding. So organic, you can see when we do endoscopy, there is clear cut evidence. Motility and functional is something you really cannot see structurally. If you talk about food pipe, somebody says I can't eat the food. You do the endoscopy, the esophagus is bang normal. Then you do their functional testing or motility testing, and then you find diagnosis like there's a term called as nutcracker esophagus. It's like it's a very old term that when somebody, the pain is so severe like you have to break a nut, and it is just a spasm of your food pipe. The pain can be as wrong as somebody having a cardiac arrest or an MI. So, and the treatment is totally different from what you would give. And mostly people come to me and they tell me, "Oh, I have gas and I always feel epigastric burning." And while we do the manometry, ultimately they are diagnosed to be something like this. And so it totally changes the way you work. So you will have 3 or 4 endoscopies and just which will be bang normal, but ultimately you will be having a diagnosis of. So what we cover is motility and functional, and what a pure gastroenterologist will cover will be only the structural. So that is what is a broad difference. Now we come back to our core topic of IBD and motility. So UC and CD both, as you all know, is a chronic relapsing disorder, needs lifelong therapy, proper follow-up. It involves an immune system, dysregulation. I'm not going to go into the depth of it all. I'm sure you must have read through all of you it, and and even we don't know much in exact detail what is a single cause. But what I need to emphasize is that this motility is part of IBD's pathology. Till now, even as residents, when I was studying, I was told, okay, you IBS ek taraf hai, IBD ek taraf hai. Let's not mix them all together. Either you are IBS or you are IBD. But that is not the case. It's actually all together. This motility is part of your IBD pathology. So motility disorders are very common in IBD patients. And there are people, like IBD specialists who will not think of a motility disorder, or who will at least not think, yeah, my patient is having IBS. They will keep on testing you for CRP, fecal calprotectin, maybe sigmoidoscopies to look into your inflammation, and they will all keep yes, that is the first thing you have to do when somebody comes with a flare. But when those are normal, you have to it where we have to understand our motility. Now this slide is very important. Motility in IBD. Let's talk about what is normal, or what is exactly motility changes in IBD. I don't say it is normal, but these are the changes I see, or I have read, or I have seen in my testing. Patients who have ulcerative colitis actually have, yeah. Oh, yeah. So, okay. Sure. So when I say motility, I mean the time taken by the food stuff to go from your, let us say, stomach to colon. So your GI tract has your mouth, your food pipe, your stomach, then comes your small intestines, and then comes the large intestines. And there are various parts of small and large intestines. So when I say motility or I say transit, I mean the time taken by the food to go from your mouth to your anus. Usually it is 3 to 4 days. So what you eat today will going to come out in 2 or 3 days. In India, because we take a lot of fiber, we take a lot of, we have a habit that everybody needs to pass their motion in one day. And actually, Dr. Uday Kushal is there in SDPJ Lucknow, and he has done some excellent studies for motility. And he has shown scientifically that Indians have faster motility than the Western population. Until now, it is assumed that it is possibly because we eat much more of fiber naturally in our diet. So motility means that. So when I say motility, so I am saying what are the changes which is expected in IBD patients. So if I talk about ulcerative colitis, most of the patients will have diarrhea, and most will have, when they have a flare, they will have bleeding. So when you listen to diarrhea, you normally expect as a doctor or even as a patient that कि हमारा transit time तो shorter होगा, हमें diarrhea हो रहा है, the food will be rapidly going down. But that is actually not the case. Ulcerative colitis is a paradox. There is a proximal constipation. As you all know, or I will explain, that the large intestine has primarily 3 or 4 parts: cecum, ascending colon, transverse colon, descending colon, and then the sigmoid colon and the rectum. The rectum is the part where the feces is all stored, and before that is part where the water and salts are absorbed. Your actual transit time from mouth to that cecum is much slower in ulcerative colitis, while you are having diarrhea, but your transit is actually slow. And that is an adaptation of your body to make sure that before the food reaches the colon, it is absorbed maximally. That's what your body adapts to do. So you have a proximal colon. Proximal matlab ke before the rectum to have a stasis, and once the feces reaches the sigmoid, that's where there is no accommodation in UC patients, and they will end up having diarrhea. Similarly, something called as a contractile response. When you eat your food, your colon is supposed to have its multiple movements. There are at least 3 or 4 kind of movements. Fragmentation, which is supposed to fragment the food. Then there is a propulsion, to propel the food down into the GI tract. So this is also decreased. So ultimately, all this goes into the fact that there won't be a significant absorption, and you will have diarrhea. Crohn's, on the other hand, is much more complex because it can involve any part of the GI tract. So the motility is much more complex, and if I start that, I think will be another lecture of pure GI this thing. So I will not delve too much deeper. UC I had to say because even gastroenterologists don't they are not aware, and they don't understand when I tell them that you are actually dealing with a state of constipation and not diarrhea, whereas the symptom predominantly is diarrhea. So it's a paradox. So now IBD, once flare is usually easily recognized. Either if you have UC, you will have bleeding. If you have Crohn's, you will have pain, fever, possibly diarrhea. So, but diffuse abdominal pain or having an altered bowel habits is not necessarily always a flare of an IBD. Let's give you a small example. You're a young female with distal UC, means only involving the sigmoid or the rectum, who is currently on local therapy or suppositories. And she complains of left-sided pain abdomen. There is no tenesmus, mean there is no pain while passing motions. The stool frequency is normal. There is no mucus or blood in the stool. As usual, she goes back to her IBD specialist, and he or she asks for a fecal calprotectin levels which come out to be normal. They might ask for a sigmoidoscopy, which will again come out to be normal. So what would you think of? Is it they will keep on thinking, okay, is this still a flare or is it something else? This might lead to an unnecessary escalation of their therapy. But this is where you have to start thinking, okay, is it something, is it IBS happening to this patient? Is it SIBO happening to? So things apart from inflammation. Similarly, you have a young male who has ileocecal Crohn's. He is on immunomodulators, but he is having persistent diarrhea. You have given them everything. You give them steroids. You have given them azathioprine. They are possibly on biologicals, but they are still having diarrhea. The CRP is normal. There is nothing wrong with the cross-sectional on a CT or an MRI. Your colonoscopy you're done after 6 months of therapy, it shows the ulcers are healing, but he still has diarrhea. Should you escalate your therapy? Should you not escalate your therapy? The problem is that when, as gastroenterologists, we keep on thinking of inflammation and we keep on escalating our therapies, but we need to think outside of inflammation. Something else can be wrong. Look at this list. It's a huge list. All these are causes which are outside the inflammation. If you have diarrhea, you may have a coexistent celiac, which is celiac in simple word means wheat allergy or gluten allergy, which is pretty common in IBD patients. You can have an eosinophilic disorder. You can have it's a huge list. I can't keep on going with each cause. So even with diarrhea, you can have this list. With constipation, you can have this list. With bloating and pain, and I'll tell you, it is very common. It's not something unusual to find them. So, in your mind, as a doctor also, and even as a patient, you have to start thinking that okay, is it only yes? The first thing you have to rule out is inflammation, whether it's actually a flare or my Crohn's is actually worsened. That is true. That's a fact. First is dash differential only, but once you have cleared that, you should not leave it at that. And there should not be an empirical escalation of therapy. So, how common are all these? I'm giving you a huge list, but what is the data on saying how common? So, 35% of QSEND, people who do not have an active disease, have symptoms which can be easily explained by IBS. One study said 66% of patients have actually one criteria where you can say they have a disorder of brain and gut axis. It does affect your psychosocial morbidity and your stress loads. So finally, what we have done now, most of the neurogastro guys, they thought, okay, the functional term is not so good, so we now say it is a disorder of gut brain axis, and this is in anticipation to future research, because now we see more and more research coming into it, and I strongly believe that in next decade or so, disorders of gut brain axis would be the main GI disorders which we all will be dealing with. Brain gut axis in IBD. So these questions, I'm sure, as a patient, you would have always thought, but as doctors, we have probably don't have any answers to it, and we honestly don't even put too much thought about it. We keep on thinking about inflammation, but we don't really think about these questions. So, does the emotional disorders predispose to IBD? That you have an underlying depression, you are an anxious person. Do you think you're predisposed to develop IBD? The next question is that does stress or emotional disorder precipitate a relapse of a pre-existing IBD? So, and if you treat these emotional disorders, can you actually prevent or improve IBD? That is your brain to gut signaling. And now we talk about the reverse, your gut to your brain signaling. Does intestinal inflammation influence the brain? Does intestinal inflammation actually alters your brain functions? And if we do your IBD therapy, does it change your mood? Now let me tell you what is the data available with that. Your emotional there are actually animal models done on various mice and other animals, where maternally deprived animals developed much more severe experimentally induced colitis, whereas mice who were with their families. Again, animal models that and even preclinical data from Manitoba IBD group, they said that patients of IBD who were having depression did have more relapse, and they have been at least one RCT and a systemic meta-analysis which said that antidepressants do help in preventing relapses of IBD. So when I talk about all these things, please assume that we have already ruled out a flare, we have already taken care, and we are at the best of our IBD therapy, which is also a difficult thing to achieve. I agree with my, even in my practice, I'm sure I might not be achieving a direct, the best IBD therapy that can be achieved because of a lot of practical reasons. Some patients can't afford, or either the drugs are not available, or there are side effects to steroids or thiopurine. So I'm assuming that all those things have been managed. Then we're talking about all these things. Okay. So ultimately, what is our therapeutic goal in IBD management? This is a slide I like the most. Okay, we are at our optimum anti-inflammatory agents. We are using whatever immunotherapy we have to use, if required biologicals, if required surgery. But on the left side, we should also be having our optimal management of our depression or anxiety or our sleep cycles, and all these things are important. And that is where you can have a wholesome IBD management, okay, and be in as prolonged remission as possible. So again, I'll just kind of quickly go through these percentages. If you can see in the slide, IBS-like symptoms, fecal incontinence, functional pain, functional constipation, functional diarrhea is all pretty common, even patients who have a silent or who have a controlled IBD. So just to tell you what symptoms actually can come, this slide came from one of the review articles I saw. If you go organ specific, in Crohn's disease, rarely achalasia has been reported. Achalasia is a disorder of your food pipe. You can have symptoms of reflux. Gastroparesis, that means that delayed emptying of your stomach to food, and the symptom being that as you eat food, your tummy is always full. That has been seen in Crohn's, because Crohn's can affect your stomach. I think around 5% patients do have it. You can have a disorders of your of gallbladder at the same time. Small bowel, there is plenty of time, particularly in Crohn's patients and in patients of ulcerative colitis after they have had their colon taken out. These patients do have IBS-like symptoms very commonly. I have one of my very close friends who was a patient of ulcerative colitis. She underwent surgery for that, and she actually developed very bad dysmotility, something like almost a pseudo obstruction. I'm not sure, or maybe you have heard this term called as CIPO, chronic idiopathic pseudo obstruction, and she is still in that for almost many years now. She's on multiple drugs for it, and it is a significantly life-threatening, not life-threatening, but life-changing illness. So that is dysmotility. At that point of time, it's not IBD talking. That is just dysmotility or abnormal movements of your GI tract. Colon and anal rectum, I'm sure you are well aware of. So IBS is actually slightly more common in patients who have Crohn's as compared to UC. If you compare UC and Crohn's, IBS is more common in Crohn's patients. So now, as I said before, are these two things same, or are we talking about two totally different? So they share a lot of common features. Some of the genes are same, the disorders of immune is same, the microbiota altered is almost the same. There are some genetic polymorphisms which are common in both Crohn's and IBS. Low-grade intestinal inflammation has been widely documented. Widely, I mean, I'm not talking about case reports. Lot of IBS data has come to said that there is some amount of inflammation. I think it's just about the magnitude and the nature of inflammation. That is the difference between the UC patients and the IBS patients. So, in my opinion, I think they are two sides of the same coin. And at some point of time, we just don't know enough right now to clearly demarcate. In fact, there's a very beautiful study which came last month, and they talked about a concept of biofilms. That when you do a colonoscopy and in the ileum and your colon, you see that yellowish biofilm happening on the mucosa. You take a sample from that and you look it under the microscope. 60% of those patients who had biofilms were diagnosed to be IBS, and 30% of those patients also had UC. So ultimately, this can be a target for even treatment. And the common factor which we are talking about in between the IBS. So biofilm is a film which covers the mucosal, layer, the mucosa of your bowel. It usually has bacteria. So what are the issues if we don't identify these kind of disorders? Obviously, the cost will go up. Your if you are escalated with biological therapies, your cost significantly goes up, particularly in India when we don't have insurance paid at high. People are paying out of their pockets, and the government doesn't cover much. You can be and end up having multiple endoscopies, CT scans, all that adds to a cost. Side effects, you might be on longer steroids. Patients who keep complaining that I have pain, but the diarrhea, everything is controlled. The doctors end up prolonging, and it's not wrong on doctor's part, because ultimately the doctor has to do something if it comes back and tells me. So what they will do is, if they have to taper the steroids in 8 weeks, they will take it up for, let's say, 12 weeks or maybe even 16 weeks. So we end up having more of steroids. Biological, if they have to taper in a year, they will take it probably 2 years or 3 years or 4 years. And there are obvious risk of serious adverse events happening. And patients also become dissatisfied that my poor quality of life is continued. So how can we identify these things? So there is some amount of testing available now. The first image is an image of something called as an esophageal manometry. The next image is something called as a breath test. Breath tests are very easy to do, completely non-invasive, something which can be done on a very OPD basis. It can diagnose things like small intestinal bacterial overgrowth very easily. And then you have transit studies. You can have motility capsules now available. It's a very simple thing. I'll give you a pellets which are slightly metallic, or radiolucent pellets. You swallow them, and I keep doing your X-rays for 3 days, and I will see if you what spectrum you lie on. If you're not able to pass your pellets out in, let's say, 3 days or 72 hours, I will know you have a slow motility. So simplest thing to do, easy thing to do, cheap thing to do. It's not expensive. Just 3 X-rays. That's all. And we can do something called as an electrogastrography. It's like an ECG you have for a heart. For a tummy, you can do an electrogastrography. I think it's not available at more than 2 or 3 centers in India right now, but we will probably get it this year. So you can do for you it can be, you can do breath test for small intestinal bacterial overgrowth. You can do lactose intolerance test very easily. You can do a manometry if you have, particularly if somebody has rectal pain or difficulty in passing motions. We can do manometry in them. If somebody complains of dyspepsia or chest pain, we can do a esophageal or a food pipe manometry in them. So all these things is available, can be done. Evidence is available. So the strategies to manage all these things is, we should optimize the trust between the doctor and the patient. We should be able to listen to our patients, as doctors. The patient should be able to communicate in a good way. A lot of time, what I find difficult is that patients are not able to tell me or communicate to me. They just use the word, like, they will say gas. Now gas is used for n number of things. It goes from belching to bloating to flatulence to burning. All this is abdominal gas. And let me tell you, 20% of them will have headache, and that headache is being told as gas. So effective communication is lost. I mean, when we read our medical books, it's all that Western literature. वहाँ पे all these words are not at all used. So I think we need some India-specific symptomatology books that we need to understand. So we need to also manage expectations. And what are we expecting if we are trying to do all these tests? So giving time to the patients, giving time to the doctors, and trying to really find out the best middle way. And then the interventions can be dietary, something like low FODMAP diet. Low FODMAP is it's a group of food, fermentable oligosaccharides, polyols, and everything. If you go online, you will be able to see low FODMAP Indian diet. It works very well for IBS per se, but even with patients who have IBS as well as IBD. And obviously, there are things like behavioral therapy which can be used, but it's no one size fits all. Every patient needs a custom based treatment. So it's my last slide. What all I talked about is not just counseling. It's not just about saying that functional disorders exist. All this is evidence-based medicine. There have been numerous articles which are now available, have been available for time. I think it is the responsibility of us doctors also that we should be able to find out about all this data, know about this data, and finally we need to trust, our patients that they are. It's not just an inflammatory flare. Thank you so much.
Thank you, sir. I think like I have so many questions for you. So like
Sure, sure.
question that I want to ask is like actually like when I started when I started following like around that same time only, like there are a lot of patients, and like I've experienced this also, and
Yeah.
our IBD is in remission, like you talked about. IBD is in remission, everything is good, but we still have that, like some have abdominal pain, some have like delayed emptying, some have problems like passing stools completely,
Yeah.
and some have gas cramps. And personally I had like, when I had active IBD, and like when my IBD went into remission, I still had the symptoms. I used to believe that like there's just no cure for all of this, like cramps and gas, or maybe something that's just not manageable, or you have to just power
Hmm.
through it. So
Hmm.
do you think that those people like or patients like who are suffering from such things, despite medication, should like consult, like should now like try to get into like touch with a neurogastroenterologist, like look for solutions here?
Yes, I think it's a very, very important and pertinent question. See, a lot of these disorders, something like SIBO, something like IBS, are manageable by a particular set of medications. If somebody has a Crohn's disease and he has persistent bloating, I will not say that just, force your way through it. Some things are diagnosable and manageable, particularly if you have SIBO. Now the question comes is that you have consulted a neurogastroenterologist. He has done some test on you, and he is sure that there is nothing else wrong with you. And the symptoms are occasional. At that point of time, yes, maybe we would also say that you forced through it. But before saying that, as I said, there are a lot of tests available and treatments available. If you have SIBO, something called a small intestinal bacterial overgrowth, which is very common in Crohn's patients, your amount, so the balance between the good and the bad bacteria in your small bowel tends to change over a period of time. When that balance goes away, what it all needs is 10 to 14 days of an orally available, locally affecting antibiotic, and that bloating goes away. How it is diagnosed? By simply doing a breath test. You come to my OPD, I give you a tester dose, and you just blow you exhale into a machine, and the machine tells me how much your hydrogen level goes up over a period of time. And within 1 hour, we'll know, okay, whether you have SIBO or not. At the same time, so that is one end of the spectrum where you have mild symptoms like bloating. Whereas the other patient I told you about, my own friend who had a very bad SIBO or chronic idiopathic fluid obstruction. Now for her, although even I have diagnosed her, I can't do much about it. I can give her a few drugs, pilocarpine and all that stuff, but it is something even I am helpless about or could give an answer about. So something, yes, we can answer, something, yes, we can treat, but at least we should start thinking about that.
And so like this is for patients, so like we talked about patients who have like their disease in remission, or like it's controlled and they are having these symptoms. Do you think that like a person who has active IBD should also be in touch with a neurogastroenterologist, like?
So active IBD, the issue is that if your ulcers are still not healing, if you have Crohn's or if you have persistent bleeding, then the first goal of therapy has to be your optimization of IBD. Until that happens, you cannot really go into the testing part of neurogastroenterology. My own IBD patients, what I personally do is when they are sort of going into remission, but not yet completely into it, I tend to add some drugs to them, which will also eventually cover some of the dysmotility if need it be. But yes, I will not sit on it in a sense that if they come back to me with a flare, the first thing I'll do is definitely optimize their IBD therapy. But yes, my own threshold, because I have an interest, so my own threshold on starting them on drugs like antidepressants or SSRIs is bit lower. And I explained to them, that this drug is not for your, just for depression. It actually also, works on your intestine, because if you read about the pathology of both Crohn's and I on and as well as UC, inflammation is one part, and the visceral or the pain sensation of your intestinal nerves and your central pain control, all that is also changed. So I do add drugs like, which I use primarily for my IBS patients in IBD also, but those are in combination with IBD. So,
So
but optimum control is definitely required.
and so like there's already a lot of stigma like around mental, even though like I think with COVID it's improving, but still like people are very reluctant to use like psychiatric drugs. And
Yeah.
but still patients are like prescribed, like when I like in my experience, whenever patient they say that okay, my doctor has prescribed me amitriptyline or like some antidepressant or SSRI, and they are very reluctant to take it. And like just to I think like repeat that point, could you just like repeat that your like intestine is
So
very
I
secondary level?
honestly face this every day, every day. Every day patients tell me कि सर आपने हमें ये ट्रिप्टोम और एमिट्रिप्टिलिन क्यों दिया है, स्टालोप्राम क्यों दिया है, अब मुझे नींद आ रही है. So
Yeah, yeah,
problem, I totally get it. When I am giving you a drug, I know these have side effects. In fact, I tell them also, to some extent. So it depends on, if a patient is like knowledgeable. If I'm trying to explain to them, I will tell them, okay, these symptoms might be there. Don't stop the drug, or you can decrease the dose to a half, but keep on taking them. The issue is that in India, we because we have so many pathies. We have Ayurveda, we have allopathy, we have
mm,
Unani, and everything, and there's so much of beliefs in certain things,
yeah,
that it becomes quite difficult for this thing to be highlighted, that these drugs are not only for depression.
mm,
And I've been trying to explain to my patients for last 10 years now, but every day it's the same.
yeah,
I hope it may improve. It all these things, like the way we are talking, does help. Maybe your listeners, might be
yeah.
more, more receptive towards if they need some antidepressants. But if you see patients who are coming from villages, who are coming from core of India, it's a fight every day, and I only hope it changes.
And so, like two other things, like there this is also like wide among patient community. Like one thing is like brain fog. We call it brain fog. I don't know like for doctor, but we call it brain fog. Like not only in IBD, but like it's common in chronic illness. But yeah, like I think a lot of us like experience this, like sudden breakage of chain of thought and like very like loss of concentration, loss of memory, sudden loss of memory. Like while speaking, we'll just stop and like we can't catch the word. And second experience is flare up just after some stressful event. So
Yeah.
like usually when we like talk to gastroenterologists about this, then like it's not there, like this thing is not like a medical symptom or something. But do you think like this could be related to the
Oh, absolutely, absolutely. In fact, I did not. Uh, I think I did show a part of it in the slides. So, though, if you remember those questions I said,
yeah,
about the brain gut axis.
yeah,
So that comes from a very beautifully written, review article, and it did show clear studies that if you have a psychological, emotional, or a physical stress, all these can actually increase your chances of having a flare. And it is a documented thing. Stressful events does induce flares, whether it's an emotional stress or it is a physical stress. It is a very clear data.
so basically management of IBD is now like management of your whole life, like you
Whole
have
life, yeah,
to.
it see things like, if you're dealing with a any chronic illness, चाहे वो chronic pancreatitis है या IBD है, you're diabetic or anything, it does emphasize your whole life.
Yeah,
Your every life, aspects has to change. So it's a life, what I say is life modification. That
yeah.
is what is, kind of required.
But like what like like your opinion on this. So like as someone like patients with IBD, like we are diagnosed very young, and then like we have to build our careers and get education and all these things are stressful, like getting into a good job. And obviously we want to do that, like as a young person, like I don't want to compromise just because like I have a condition. Like I'll always try that I can get the best out of myself. So like what advice would you give to like young people with IBD? Like, how do you create that balance? Or like, I like somewhere also we also have to compromise that. I recognize, like you said, managing our expectations. But yeah, like as a doctor, what advice would you give to like young patients with IBD regarding this?
So I have seen this on a very personal level also. In my own family, uh, I believe that don't, in fact, do not compromise. Find out solutions, what you can do. If you keep on thinking about your problems, if you keep on thinking about your disease, you will not, come out of it very easily. Find solutions to what you can do. Always try to move ahead. As patients, I totally understand that your disease is life changing, your disease is life altering, and it will remain with you for your life. But that is not the end of it. There are certainly many people who are, much in a much bad state than probably you are currently. But as if for your own careers, you can certainly find something which you can do in a very best way. And just don't give up, just don't compromise, just don't say that, okay, I'm okay with this. If you're okay with this, that tells me that you can certainly do much much more, and you can easily do it. In my own family, I've seen in my own, my own one of my own uncles, he couldn't see from very early on in his life. He ultimately did his PhD in English. He became a professor. He became a dean. And, with the one major sensory organ not working, people can do it. It's just about having that mindset that you can do much more.
Thank you, sir. I think like that, like it makes me very happy, like coming this from a doctor, because like even among patients, like there is this mindset that just like settle or like just compromise or like don't do this job, don't do that job, and it's really hard to find people like who encourage like do follow your dreams or like do what you want.
You
So
should
yeah,
be able
thank
to
you
do.
for
I mean,
that.
that's the ultimate goal for us doctors. We shouldn't be asking you to, compromising in your life. In fact, we should be partners with you to try to find solutions to with your problems, and how can you deal with your problems.
Yeah.
We shouldn't be, I hate when doctors, or even doctors or anybody for that matter tells me, okay, this is the problem. I just tell them, I know what is the problem. If you have a solution, you tell me. Don't just keep on increasing the number of times problem is said. So that
And
is
so,
important.
yeah, coming back to neurogastroenterology, like the test you mentioned, like in my experience, like uh, from whatever like my interactions with other patients, like Indian IBD patients, like we focus mainly on our IBD. Like
Yeah,
we are always battling through that only, like
yeah.
getting medicines and managing cost and everything, and all talk about this like this SIBO or gastroparesis. Mostly, I have heard it among Western patients only. Like they do all this advanced testing, and like they are able to like. I don't even think like we can get that diagnosis. Like I didn't used to think like before this talk, like we can get the diagnosis here, or like we have the time or like the financial condition or like the money to like pursue all these things. So like what is the state of all this testing and like in India, like how expensive is it, and like what conditions can
So
be tested easily?
it's not actually very prohibitively expensive. Things like significant reflux or GERD or eclasia, which require esophageal manometry, can be done in multiple places. In NCR, there are at least two or three places where you can get it done. In Bangalore, I'm sure there must be two or three places. Hyderabad has a lot of places. Bombay has. So manometry is actually now available, but problem is not everyone is doing it that well. They do have the equipment available with them, but they're not doing it so, and they're primarily doing it to diagnose it in non-IBD, or primarily doing it for something like eclasia. Then gastroparesis is something which is slightly more tricky. Gastric emptying scans can be done, which are available with nuclear medicine departments. It's there in Medanta and other places, and in Delhi a few places. And something called as electrogastrography, which is again a functional testing of your stomach, is not readily available. I think Chandigarh has one center. We will be probably getting it in 6 months. There's still talks going on with the manufacturer, and maybe one more center in India, only two. And then if you talk about SIBO, breath testing is widely available. That is something we should be. In fact, many doctors, they don't want to test it. They will give the treatment for it if they suspect that you have SIBO. To an extent, it is okay. I don't disagree with it, because the testing itself costs you around 2,500 rupees or 3,000 rupees to get it done, and the treatment is 50 rupees tablet, possibly for 10 days. So it's fine, and there are no major side effects of it. So if you talk about the pellet study, very cheap to do. Maybe it shouldn't cost you more than 300 rupees to get that pellet study done. Unfortunately, not many people do it. Why, I don't know. It's very cheap to just do it. That is also available here, and I think major the centers will be having it. Then, if you talk about colonic manometry is not easily available, whereas the rectal manometry is still available. So, if you have disidentification, it is easily available. So, all these tests, the most expensive one will also not cost more than 10,000 rupees. It's like getting a colonoscopy done under sedation, that will also roughly come around 9,000, 10,000 rupees mark. So these tests are not that expensive. There are some new ones which are not yet in India. I think only one center has something called an endoflip for gastroparesis. It's an endoscopic functional testing. While doing endoscopy, we will put a balloon inside. That is for gastroparesis, and primarily done to be done only when we are thinking about surgical corrections to gastroparesis, and that is available in US. In India, only Asian Institute has it in Hyderabad, and that was primarily for research. They made a publication with it. I think if and when it will be approved, it will come. Then capsule endoscopy is primarily used for bleeding and Crohn's, but it can also be used for motility. That is expensive. That is around 50,000 roughly. So it is available and not very expensive.
And sir, like you said, like IBD in itself is like explanation, even like explaining IBS, like the best explanation of IBS I used to give was like there's nothing wrong with you. It's just like
Yeah,
there's
yeah.
something wrong with your like nervous system or something. That's what I used to tell patients. Like there's nothing wrong with the gut or something. It's like something related to nervous system. But then like when it came to medications, I couldn't explain why like they are having to take. So and IBD is also like a complex thing to explain, and mostly like you said, the core of India, they go to government hospitals. Majority of them can't afford it, and like there's very like little consultation times also. So like they do you think there is a need to like educate patients about like this part of gastroenterology, like tell them about this, or like right now it's not like a good thing?
So as I said, right now it is more of a niche, this thing specialty. Even if you want to explain to the core of India, and ultimately they will say that why do we need this, until it drastically. You see, in India we have a habit of quick fixes.
Yeah.
Okay, I have a gallbladder stone, get a stone out, or get the gallbladder out. These are chronic illnesses, and they keep on needing repeating various tests, different kinds of treatment. uh, I don't think mentally, Indians are yet ready for all these kind of diagnosis. We are talking because we are probably empowered enough to have exposure to Western literature and Western patient groups, and with all this Facebook and everything available. But the main crux of India, which I also see during my OPDs, it's very hard to explain this to them.
Yeah.
I tell them that I'm doing a manometry study or I'm doing a gastroparesis study, but ultimately I'm going to give you a domperidone. Ultimately, I'm going to give you a PPI and a domperidone combination. तो बोलते हैं सर आप पहले दे दो, which is not wrong in their
Yeah,
own
like from their perspective
from
also,
their
like
perspective. But yes, if you want to prove a disease, if you want to be scientific about it, and in future, if you go, or even not, if you want to go to a stronger medications than simple domperidone or PPI, then yes, you should be able to test it. It needs more awakening, and the only issue is our I use the word as health IQ. As Indians, our health IQ is pretty poor. I think in school and everything, we are not really taught about health per se for many years, and that's where we are lacking.
Yeah. And so, one, like this is related to patients. So, like, there's this common thing, like, I have like heard it from like just before this talk, I got two, three patients like who were talking to me about this. Like, it's like they can't, pass the stools completely. Like, they have
Yeah.
to dilate their anuses to, like,
Yeah, yeah, yeah.
so like is this like can they explore like neurogastroenterology for that? Like the that person has like is on mesacol and everything is okay, like no CRP, no, and then they are having this like persistent symptoms. So should people who have like symptoms like this should like consult a neuro GI?
Yeah, so this is a feeling of incomplete evacuation. It's a very common thing. It is usually in patients who have dyssynergia or their coordination between their passing of stool and the relaxation of anus is not there, and this happens usually in UC patients who are in inactive state. Or I mean, I'm only in IBD I'm talking about. Otherwise, it's actually very common. But in IBD, it happens in UC patients who are right now in a silent phase. They don't have a bleeding.
Yeah.
That's when they will have this. So they should get a if they want to diagnose it, they should get an inert method done that is easily available, not very expensive.
And so I actually forgot my last question. So yeah. Like, what is the like in my like whatever I could found, like I could only find you. So do you think that like this field is being adopted, or like this is going to be a different field? Like how many neurogastroenterologists are available in India right now?
So if you talk about hardcore neurogastroenterologist, which I'm also not right now, because at, at my level of profession, I don't have the luxury of only working with neurogastro, although I would like to. I do have to take care of general gastroenterology also. So if you talk about hardcore gastroenterologists, people who are exclusively working the way they work in US and UK, then there will be not more than 4 or 5 in India.
Okay.
But if you talk about people who have a special interest in neurogastro and also they're working with general gastroenterology, then there are people I know of my own circles around maybe 10, 15 all over India. If you talk about are all of outside of this 15-20 circle, there are people who are obviously aware of all these things, but then they either don't have the patience or the testing available with them. So they will usually end up treating you or giving you the drugs, assuming that you have IBS or gastroparesis or reflux disease, but they might not be testing. If you come to me, then yes, I will be testing you first and then giving the particular treatment. So that is the numbers are. But in US or UK, there are people who are only working with esophagus. There are people who are only working with gastroparesis. There are people who are only working with IBD. So that kind of very high-end specialization is not yet widespread in India.
And so like I got to know about like GI psychology, and like there's the Rome Foundation also in the West for like
Yes,
they maintain a
yes, yes.
database. But like there are no psychologists in India. Like so like is this a part of neurogastroenterology, or like is it like ahead of it or like separate from it? Like where does that
I
stand?
will love to have a psychologist in my team who can exclusively work with these patients. Unfortunately, uh, there are not many people who want to work with in this particular field. And even the various departments all across India, they will not want to invest or pay salary to one guy only working with neurogastro, IBS patients. So ultimately, it ends up with us, people who are working now. I do biofeedback sessions for my patients who have dyssynergia, who have all this feeling of incomplete evacuation. Now, 60% of biofeedback is counseling sessions. So because we don't have counselors available so easily who want to work, so ultimately I have to do it in my own personal time. So if I'm not able to do it well, the patients will not be very happy about it. So there is a draft need for all these counselors and GI psychology. They are available outside of India. In fact, if you talk about neurogastro centers across the globe, it usually has one or two doctors. You have a neurogastro GI nurse, and you have a GI counselor, and you have one technician who is also expert in all this motility testing. So these four or five guys usually make a team. If you go to Hopkins and Mayo and all that, their neurogastro units are like this.
Okay. And so my last question is this. So like I started like along with like like patients, we started this like last year. And basic goal was to like first it was to spread awareness. Then like we saw like it could be used to educate patients. Then we saw that okay, like we can use it to like advocate for better laws for like people with chronic illnesses, rare illnesses, and like things like insurance and all of this. So like how can a patient group like us influence or like help doctors or like like be a part of this ecosystem? Because like you said, like there are a lot of things like that are like lacking compared to the like the IBD treatment ecosystem in the West. And I think like our doctors and nurses are also like there's a huge load of patients also, because of which like there are many constraints. So as a patient group, like what efforts can we do, like to help doctors and to like influence all of this or to like support patients?
I think it's a very good question. I'm forgetting a story right now. I think I read it a few months ago. So there was this patient group in US, and they probably it came from the patient that we should try to identify this particular set of testing for these symptoms, and that's how almost a new technology was born, uh, which actually helped various doctors to diagnose a few things. I'm not completely remembering the exact story, but to tell you in a crux, recently a lot of international associations have included a patient group or a patient member in their guidelines. Why? Because only sitting as doctors from one side of the table and making guidelines for patients, and other doctors to follow, it may not reflect the complete burden. It may not reflect the complete symptomatology. So patient support groups should be a part of, or there should be a strong advocacy from the patients to have support groups by each major hospital. So if I am heading a patient support group, I will reach out to major hospital chains like like Fortis, Apollo, or whatever, or Medanta for that matter. That okay, we will create, or we will, as an association, we will become organized. We will employ a person. Please refer, and this patient will be in your department. Please send all your IBD patients for counseling with us, and we will work as IBD counselors.
Yeah.
As a doctor, I will be very happy because that takes a lot of load off my mind, and I will know personally that my patients are in good hand, who can guide them in a correct manner. So strong patient advocacy is the most important, if and completely lacking in India, if you really want to make a difference. And you should be able to contact the various hospitals, contact their CEOs, their MDs. You can Doctors themselves might not be able to make these decisions because they are not really a part of the core management group.
Hmm.
Now it is improving, but it's not yet. Then online presence support groups is very important. I think a lot of other Parkinson's and neuro and other disorders have a strong international online web presence. Then as you we are having this discussion, this can be a wider, with multiple doctors and multiple groups. You can have a whole conference kind of a thing. So all that will give you more vision, and once you have vision, you will be able to be have a stronger rights for patient, which is I totally believe is very much necessary.
I think you'll be happy to know, sir, like we are actually working to on this, like creating an IBD counselor program. We are actually working on that. So hopefully, like,
Totally, I think you should have a certified
yeah,
program for
yeah,
it,
yeah. Actually,
and
we are talking to some people like to help create this program, like get it widely adopted, and because
that will be
a
that will be
lot of
good. That will
doctors
be
have
good.
expressed interest in that. So
That
yeah.
will be that will be good. That will be good.
So thank you, sir. Thank you for giving us so much of your time. Like it's almost an hour. And like talking to us
Okay.
about this like very new and like complex and like I think necessary topic also, which I'm sure like it's like all the people watching this are going to relate, because like everyone has faced like some symptom which is not explained or like not treatable
Yes.
despite taking every drug. So thank you so much, sir. Thank you for giving us so much of your time. Yeah.
Thank you so much. Thank you so much for inviting me over. Thank you.
Thank you, sir.